Good morning, everybody. First of all, I would like to thank Catherine Moore and the local team, as well as Montserrat Espuña, for inviting me to talk to you about the conservative management on stress urinary incontinence. As you know, urinary incontinence is a common problem. It is more frequent in women than in men. It's very common in the elderly and even in young active people. According to the International Continence Society, urinary incontinence is defined as the involuntary loss of urine causing a social or a hygiene problem. The definition of the different types of urinary incontinence as a symptom matter are those of the International Continence. Stress urinary incontinence and urge urinary incontinence being the two most frequent leakages in women. It is important to know that not only is urinary incontinence a serious medical problem in which skin or infections are involved, but it's also an undeniable social problem, creating embarrassment and negative self-perception. It is known that urinary incontinence also reduces quality of life, physical activity, and social interaction, and it's also a matter of money. Estimates of prevalence reflect the type of definition, whether it is a condition, a symptom, or a sign. It's influenced by the sample of population and the type of questionnaires used. In addition, figures aren't likely to show the real number of urinary incontinence cases because of the embarrassment and other factors that makes it underreported. Most studies have been conducted in the States, Canada, Europe, Australia, and Japan. These studies have estimated that incontinence in these women is between 30 to 60%, a mean urinary incontinence prevalence in Europe of about 35%, and 20 to 50% in Spain, as reported by Espuña and colleagues. If we look at the biggest prevalence study about urinary incontinence ever done, we can see how its impact and severity increases with age. And stress urinary incontinence cases are more frequent than other cases. So, if stress urinary incontinence is the involuntary loss of urine associated with an intra-abdominal increase of pressure without the sense of urge or the involuntary detrusor contraction, it is known that some factors are able to predispose to incite or promote it, such as pregnancy and vaginal delivery, family history, bedwetting during childhood, increased intra-abdominal pressure, behavior, hormonal situations, as for example menopause, illnesses, surgery, and obesity. In the same direction, Heather Grua and Linda McLean have classified and defined these factors as the interaction of three structural systems: the intrinsic urethra closure, the urethra support failure, and the lumbopelvic stability deficit, as well as three modification factors, as they are the motor control, the musculoskeletal, and behavioral. In order to treat these conditions, the first line of recommendation that is still current is the conservative management, which covers two areas, this being behavioral therapy and physical therapies, as the slide shows. There are needed more studies to assess the effect of a specific lifestyle change on stress urinary incontinence. However, it is known that these factors should be considered: massive weight loss in obese women, fluid intake, type, quantity, and when, constipation, smoking, coughing, and other types of chronic intra-abdominal pressure, some types of medicine, and heavy lifting. Now, if we look at the physical therapies, the first thing we must review is if all women are able to perform an effective pelvic floor muscle contraction. It is known that more than 30% cannot contract in an effectively way, which is tightening cranial and forwards. Only 49% increases the urethra pressure during the contraction, and some others are using other muscles, such as adductors or gluteus, instead of pelvic floor muscles. So, the vagina pelvic floor muscle assessment in quality and quantity is needed to determine any future programs. Assessment could be done by using the Oxford Modification Scale or the Perfect Scale, which is going to be explained this afternoon. Secondly, it is important to respect specificity, overload, progression, and maintenance in order to alter muscle morphology by increasing the cross-sectional area and the number and frequency of motor neuron excitations. The American College of Sports Medicine, as well as the International Continence Society, recommend having a specific muscle training, performing 8 to 12 slow velocity near maximum contraction for endurance, or less and faster for power, to perform it 3 times a day, 2 to 4 days per week, and for more than 5 months to be effective. So the important points in pelvic floor muscle training are to be able to perform a correct pelvic floor muscle, be assessed, the strategy or to be able to perform the neck maneuver, which is the rapid contraction whilst coughing or jumping or that kind of things, to improve endurance as well as the elevator plate tone, and to achieve the coactivation of the transversus abdominis and other deep muscles when necessary. The following methods we can use have been well studied. It is known that pelvic floor muscle training alone is better than no treatment, placebo or inactive control treatment. High-load intensive training is statistically proven to be more effective, and quality and supervision, as well as motivation, are necessary to attain maximum results. It seems to be better to practice these exercises in different positions rather than in the standard position. Biofeedback is used to give an indication of bodily processes, usually for the purpose of changing the measured quality, but biofeedback is no more effective than pelvic floor muscle training alone. We must remember biofeedback is not a treatment on its own. It's only an agent to help training in those women who find it motivating. It is important to know that it seems to be a part of motivation by the patient and supervision by the therapist that works. Regarding electrical stimulation, it seems to improve the pelvic floor muscle function in tone and in strength. But there is a wide variety of stimulation devices as well as protocols used for the same condition, and that makes it difficult to make recent choices about the best parameters. However, electrical stimulation has been found to be better than no treatment on stress urinary incontinence. The electrical stimulation we normally use is between 20 to 55 Hz, biphasical compensate rectangular wave, during 20 to 30 minutes. Finally, a variety of weighted vagina cones, as well as geisha balls and other devices, have been developed since Plevik in 1985. It seems to be the sensation of losing the cone that makes a strong sensory feedback, prompting the pelvic floor to contract in order to prevent the cone from slipping. Vagina cones have been found better than control treatments for subjective reporting cure in stress urinary incontinence, and recently Porta and colleagues have found that geisha balls seems to enhance the treatment. So for these women who can use them and are prepared to use them, vagina cones can be offered as a first line of conservative therapy. Summarizing, pelvic floor muscle training is the first line therapy recommended for the conservative management of stress urinary incontinence, and clinical recommendations to take home are to teach the patient about the pelvic floor muscles, to explain a correct pelvic floor muscle contraction, to assess pelvic floor muscle contractions. If the woman is able to contract, set up an individual training program to be conducted at home. Aim for close to maximum contraction, building up 8 to 12 contractions 3 times a day. Suggest where, when, and how it should be performed. If the woman is not able to contract, try biofeedback, electrical stimulation, proprioceptive tapping, vagina cones, geisha balls, or wherever you need, or massage. Supervise training individually or in groups. Ask women to perform the neck maneuver. Review and coordinate abdominal functions and posture. And assess incontinent leakage and quality of life before and after treatment. Therefore, we all should continue working. Have a nice meeting here in Barcelona. Enjoy the city and the meeting. And thank you very much for your attention.
May you like to be kind enough to explain to us what is the neck maneuver in some more detail, please?
Okay, thank you. The neck maneuver is to be able to perform a rapid, a fast contraction some microseconds. Antes is before? Before doing a increase in pressure into the abdominal cavity.
Is my understanding correct that what you are aiming to say is that first, consciously, which is voluntarily, we are contracting our pelvic floor because this is unisex. Both sexes have the same type of contractions of the pelvic floor, and then you cough.
Yes.
Thank you.
Yes. You need to be trained, and finally it becomes automatic. But it's really difficult to make it becoming automatic.